Welcome to Dental Business RX. Practice success in 30 minutes or less.
Thank you for calling ABC Dental.
Do you have a treatment coordinator in your dental practice? If not, do you think you might need one? And let's say you do have a treatment coordinator. Is it possible that you might need more than one? With proper division of labor in a dental practice, every job has a specific measurable outcome. For instance, a schedule coordinator, you would want, if you take a look at what you might want from one of these folks, you'd want a full, properly scheduled, efficient, productive schedule, and you could measure their performance by the statistic of production. If you had an associate doctor, you'd expect well-done, high-quality clinical treatment, and you could measure their performance again by production, at least their own individual production, and so on. Well, what would you expect of a treatment coordinator? In essence, your treatment coordinator is your sales department of your business. So you would expect patients who have accepted treatment plans and have started them, and you would measure a treatment coordinator's performance ultimately by income. And being that income is so vital to any business, it's critical that someone owns that job. In a smaller practice, the person who does that job might be the office manager in addition to his or her duties. But at some point, as the practice grows, you're going to need a treatment coordinator full time. And believe it or not, with continued growth, you may need more than one. I've seen practices with 4. So at what point would you know when to make this call? Well, that's what I want to talk about in this week's episode. My name is Jeff Bloomberg, and I'm your host. And I think the primary confusion with the whole subject of treatment coordinators derives from its newness in the industry. I remember the first time I heard the term treatment coordinator was probably back in the early to mid-90s. And it was mainly the only practices I saw that had treatment coordinators were orthodontic practices. And then, as time went on, you saw that position start to migrate to general dental practices. So this is really only a job that really you've seen a lot in dental practices for maybe the last 15 or 20 years. The other problem is that the job description for treatment coordinator varies from office to office to office. It's not standardized. If you tell me someone is a dental assistant, I would have a pretty good idea of what that person does, or a dental hygienist. I would have a pretty good idea what that person does. Whereas in some practices, the treatment coordinator is in charge of the schedule. In others, they only work with new patients. In others, they have they're more the salesperson, as I'm talking about. So it really varies depending on the practice. So when you're talking about do you need a treatment coordinator, your definition and mine may be completely different. So I may look at your practice and say you absolutely do need a treatment coordinator, and you have no idea what I'm talking about. And to give you an idea, we talked about the treatment coordinator position on this podcast back in episode 5, specifically, what are they supposed to do? We've also made several YouTube videos about it. I'll link to them on the episode webpage if you want to watch them. And also on our online platform, DDS Success, we have a whole treatment coordinator course if you have someone in your practice who fills that role to watch. But in a nutshell, from our perspective, the treatment coordinator is the sales department. They're responsible for practice income. That is their statistic. Their job is to get patients to accept and start treatment that will make them healthy, restore health function and aesthetic. Now, a lot of people could boil that down to that means they sit with the doctor when the doctor presents a treatment plan. And I've done numerous episodes on sales. Ideally, the doctor is participating in the sales process. They absolutely should. But generally speaking, the doctor's not going to sit down and run a finance company application or go run a credit card. They have a treatment coordinator to take care of those things and make sure that the patient ends up on the schedule, especially when it comes to the financial discussion. But so if you're looking at it from that perspective, that's all a treatment coordinator is supposed to do. They sit with the doctor or sit with the patients and tell them what they need and get them to sign up for it and schedule for it. That would give you a pretty limited view of the treatment coordinator position. There are also outgoing actions that go along with the job. For instance, following up with patients who didn't accept their treatment, or maybe had to go talk to a spouse, or maybe were in the middle of refinancing their house and couldn't sign up for treatment right now. So we're following up with those folks. But also, if you take a look, every practice has an incomplete treatment list. And most offices don't know what to do with this. Some look at their incomplete treatment list and have this sense of comfort wash over them, thinking they have all this incomplete treatment to do in their charts that they're still not doing. Others look at it with dread, thinking, what's going on? Why do I have all these patients not accepting treatment? But there's something you're actually supposed to do with that list. And as far as what a treatment coordinator should be doing with it, ideally, Your treatment coordinator should be following up with these patients and, depending on their circumstances, getting them scheduled. This is what they're doing when they're not sitting with you, the doctor, presenting a treatment plan. For instance, let's say I'm your treatment coordinator, you give me the big old incomplete treatment list, and I find some patients on it, because you're going to have patients from all time periods. I have patients who are overdue for their cleanings. So we have a whole bunch of those, right? Well, if I'm the treatment coordinator, what I'm most likely going to do is just follow up on those patients and get them back in on the recall schedule. Maybe it's been 4 years. They're coming in for a new initial exam, or, I'm just getting them in for a regular hygiene exam. I'm getting these folks back in because once they get in and they see the doctor, the whole process begins anew, and we can, represent that treatment plan. And chances are, if they haven't been there in a while, the treatment plan may have changed, right? It might have gotten bigger. Also, let's say we have patients who aren't due for recall, and the doc presented a treatment plan, or I presented a treatment plan with the doc 4 months ago, and the patient didn't accept at that time, and I want to get them back in because I have a better shot of getting the close if they're in front of me rather than trying to do it over the phone. I might have them come back in. The doctor wants to see them for a minute to make sure everything's staying stable. All right. But ultimately, I have those outgoing actions as well, which are an integral part of my job, especially if I have a really large incomplete treatment list. I should be following up on these people to get them back in because, why is the practice here? We're here to get patients healthy. These patients aren't healthy. So that part of the job is critical, along with, doing the face-to-face treatment presentations. So I have to have time for both. So normally how this works in a dental practice is usually it's the office manager who is the first treatment coordinator. Once he or she has sort of divested themselves of the other front desk jobs, they're not having to schedule patients anymore, answer the phone and whatnot, then they're doing some of the treatment coordinator functions. The point at which they need to start looking at bringing another treatment coordinator in, or someone to really be the treatment coordinator full time, is, let's say you have an office manager and they're spending 3 to 4 hours a day in treatment discussions or financial discussions with patients. So that's about half their day that they're doing this. Well, while they're doing that, they're in a room, they're sitting at a desk, they're not looking at what's going on around the practice, they're not aware that a big cancellation just happened tomorrow, they can't do anything about it because they have to put all of their attention on this patient in front of them. They're really no longer managing at that point. So if that's happening for several hours a day, and mind you, we haven't even mentioned the office manager getting on the phone to do those outgoing actions that the treatment coordinator is supposed to do, then it's probably time to get a treatment coordinator. It might be, let's say you have 2 hygienists and you're getting 2 to 3 new patients a day, so there's 5 to 6 treatment discussion encounters happening per day. Then, and with no time on the phone, you probably need to get somebody. So how would you go about finding somebody for this position? Well, ideally, you'd find somebody internally that you could promote to this position. There's nothing better than promoting from within, especially because they already know the practice culture. They get along with the rest of the team. They know how things are done here. So you might have a dental assistant, for instance, who dental assistants make great treatment coordinators, by the way, if they are willing to communicate, if they're good communicators, because they're already familiar with dentistry and the terms and what different procedures mean, and they've watched the doctor deliver these procedures, so they have confidence in the doctor's clinical skill. So you might promote somebody like that. And how would you get them on the job? You'd have to get them trained. That's why we have training courses, like I mentioned, on DDS Success. I'll put the link on the episode webpage. It's a shameless plug. But you'd want to get them trained, and then you'd want to apprentice them a bit. So it might be they sit in with you while you're doing, as the office manager, doing some of these treatment presentations, and you get them to take over the easy bits. Okay, so we're going to run an application now for Mr. Jones here for a small treatment plan. And they get it done, and they get everything signed. And then they know how to do that. And you feed them more and more until eventually they can close the larger treatment plans. And the only thing I would say, as the office manager, when you're closing larger treatment plans, it has such an immediate impact on the practice. And there is a little bit of excitement or, credit associated with that. It's exciting. You have to remember, as the manager, your job's to manage. So ideally, the practice is growing so much that that's what you have to do full time, that you have to have people doing the individual jobs, and your job is just management full time. Don't get stuck into having to do an individual job. Maybe you love doing it, maybe you enjoy it, but as a manager, that's not your job. Ultimately, it's to get other people doing those jobs, right? So you bring that's when you'd probably put somebody on the job. Ideally, you hire internally. If you can't, you go outside the practice and you bring somebody in. And if you have days that are super busy, you might have to be the backup treatment coordinator at that point if the treatment coordinator is still locked down with the patient trying to wrap things up. So when might you need to add another treatment coordinator? All right. When might that happen? Well, it has everything to do with traffic. The amount of traffic the treatment coordinator is having to handle. And I could give you a thumbnail assessment, but it would be a bit, I wouldn't rely on this, as if it's a law per se. But I would think, 5 or 6 patient encounters a day. If I'm doing that, it still gives me time to be on the phone. That would be about right for a treatment coordinator, especially if I'm still having time to make those outgoing calls and outreach. If I'm not having time, you keep in mind that's a job that's no longer getting done. So ideally, that's how that might work. But it has everything to do with traffic. So let's say, for instance, we have a practice that just started a huge marketing campaign and we've gone from 40 new patients a month to 100. Well, 100 new patients a month, if you're working a 16-day month, is, 6+ a day. That's probably a full-time treatment coordinator just to handle the new patients, if not more than one, because I'm assuming you're also having a considerable amount of hygiene coming in, especially if you're getting that many new patients on top of the new patients. So someone has to take care of those patients. Or you might have issues where you have a specialized type of marketing. Let's say you're doing an implant funnel, and there's most implant funnel leads, especially today, are not call-ins. They are form leads that you're supposed to then follow up on. So if you're getting a bunch of leads per day, someone actually has to be on the phone to get these people in. And you're spending a considerable amount of money on these leads. So you don't want to just put anybody on the phone with them. And, the leads, if they pan out, can be larger cases, especially if you're doing all on X type cases. So you would want somebody who is really sharp making those outgoing calls and handling the patients when they're getting them on the phone. It might be, you might have 2 people doing it. It really depends on volume, right? What about your hygiene department? If you have a lot of hygienists, then you might need someone who's just keeping up with those. But traffic in a dental practice usually has a lot to do with the patients you are not seeing. So if we were to take sort of the average dental practice as an example, just the base dental practice that you see in the United States and Canada, and I've seen a lot of these. Generally speaking, the 2 biggest problems in these practices are case acceptance and retention. All right, those are the largest problems. And the reason they're problems, it's one thing to have a problem and know it, right? You have a problem and you know it. And it's another thing to have a problem and you have no clue that you have a problem. So let's say you think you can sell and you look at, I'm good at case acceptance. I'm good at treatment presentations. But you really aren't. That's worse than knowing you're bad at it, if that makes sense. And bad's maybe a strong word. Maybe you could use some improvement. How's that? So it's better to know. Maybe you find that, well, all my patients do whatever I tell them to do. Well, so if you tell them they need 6 crowns, they accept all 6 on the for the most part? No. They accept just what insurance covers. I'm good at sales. Well, you're not. You have there's treatment plans that you're losing. And beyond the financial implications of it, these are patients who are not getting their full treatment plans done as diagnosed by you, which can make your career less fulfilling and, worse, your patients less healthy. Well, similarly, you may think you don't have a retention problem when in fact most offices do. The dental industry is a real problem. I don't know how else to say it. I've said it before in many seminars and different episodes, but it's a real problem. So let's take, for example, I want you to imagine a practice for a minute that's seeing 40 new patients per month for the last 5 years. I think the average in the U.S. is 30 to 40 new patients per month. But let's say that's you. You're seeing 40 new patients a month, pretty much month in, month out. Some are higher, some are lower, but let's say that's the average for the last 5 years. Well, my first question to you would be, how many of those patients do you think you might lose that just don't come back? The average answer I get is anywhere from 10 to 20%. So let's say 20%. We'll use that as an example. But you're getting 40 new patients a month for 5 years. So you're getting 480 a year. So over a 5-year period, you saw 2,400 new patients. And you feel like you would lose about 20% of these. So then you're left over with 1,920 patients out of the 2,400 new patients you've seen in the last 5 years. So let's do some basic math, which I am loath to do on the podcast, but I do anyway. So whatever. We're all in for it here, folks. So if I have 1,920 patients left over the last 5 years. And this doesn't count the patients I've gotten before that, by the way. Let's multiply that by 2 for the number of recalls, minimum number of recalls these patients are going to need. So that would be 3,840 recalls a year, recall appointments in my hygiene department. Let's say we work 50 weeks a year. We take 2 weeks a year off. So if I go 3,840 recalls a year and I work 50 weeks a year, that's 76.8. We'll call it 77 recalls per week. 77 recalls per week. That's almost 10 days. It's 9.6 days of hygiene a week just in recalls. All right. So just to cover my recall appointments, let's say it's a 4-day-a-week practice. I need more than 2 full-time hygienists just to cover recall. Just to cover recall. Now, let's say we're doing scaling and route planning, and we're also seeing new patients, initials at least, on the hygiene schedule. Say we're doing 2 to 3, or let's say 2 scaling and route plannings a day, soft tissue management appointments on the hygiene schedule. So if I'm seeing 2 scaling and route plannings or 2 soft tissue management patients on the hygiene schedule a day, plus the 9.6 days of recall, I'm now at 10.6 days of recall in my 4-day week. And then if we add the new patients, we're at 11.585 days of hygiene, 11.85, roughly 12 days of hygiene. That is 3 full-time hygienists per week on a 4-day week. If I have 12 days of hygiene divided by 4, I have 3 full-time hygienists needed for this practice. Now, if this is just me as a solo practitioner, I probably can't keep up with 3 hygienists, so I'm probably going to need an associate. And this is just on 40 new patients a month. Do you see? So if this is you, because the average is 30 to 40, and you don't have 3 full-time hygienists and probably need an associate, because if you're trying to keep up with 3 full-time hygienists and you have 3 patients that need an exam in the same hour that you're doing a root canal, you're not going to be able to keep up. It's actually going to slow your production down. It's not going to work. So if that's not you, if you don't need an associate and have 3 full-time hygienists on 40 new patients a month for the last 5 years, what that tells you is you have a retention problem. But now, let's say you had 3 full-time hygienists and it was you, maybe a part-time associate now because you've gotten so busy. How many treatment coordinators would you need? Because you'd have a treatment coordinator having to keep up with 3 hygienists and 2.5 new patients, 2 to 3 new patients a day. Things would start to creak a bit there. The office manager would find themselves having to jump in and back the treatment coordinator up quite a bit just based on the sheer traffic. If you were to drop more new patients into this scenario, maybe an additional 2 or 3 a day, you'd absolutely need a second treatment coordinator at that point. And most likely, you would have one working with just recall and the other working on just new patients. So let's say you had 3 full-time hygienists and 5 new patients a day. You'd probably have one treatment coordinator just working the new patients and another treatment coordinator handling what's ever coming out of recall. Because between those patients and recall, 3 full-time hygienists, you're going to have 5, 6 encounters a day with patients with outstanding treatment. So again, a lot of it depends on volume and how things roll in your practice. But like I said, the bigger problem is, like in a scenario like this, is what you're not seeing, because a lot of those offices getting 40 new patients a month have maybe 2 hygienists and 1 doctor. They're lucky to fill those 2 hygiene schedules. So if you're looking at growth and you're looking at, do I need more treatment coordinator time? You have to look at those factors of traffic, but then you would also want to look at what traffic am I not seeing? Because there's something else to think with here as well. You'll notice that you sort of have, and I hate to rate patients this way, your quote unquote best patients, your quote unquote mediocre patients. It's, what grading criteria are we using? You might have somebody who's perfectly nice. They just aren't super compliant, right? But let's use the idea of a good patient as somebody who's compliant and, dentally aware, wants to take care of their problems and doesn't tend to delay. That's your top tier of patients. Well, your top tier is not the majority of your patient base. It never will be. You know what I'm talking about, right? The patient who comes in and you go, wow, why can't I have 2,000 of these people? Well, that's not the way things work, right? People are different. I mean, there are patients you absolutely don't want in your practice, but again, that's not the majority of your patient base. These patients are trouble, right? They're going to cause problems. They're going to chew up your staff, give everybody a hard time. Those folks you don't want. And then you got the top tier who you really want. Well, in the middle is the majority of people. They're just people. They're just normal people. So the problem with most hygiene schedules is that top tier of patients, let's say I'm a really aware dental patient, and I don't ascribe to the dental IQ concept. I think that's completely bogus. But let's say I'm a really good dental patient. Dentistry is important to me. My oral health is important. I come in, you tell me what I need. I'm a new patient. I do it, without delay. I want to get this taken care of. And then I find out I have a checkup appointment every 3 months. Well, I never miss that checkup appointment. Maybe once in a blue moon because of a family emergency or I have to be out of town. But for the most part, I am reliable. You're not going to have to chase me to put me onto the hygiene schedule. I chase you if I don't have an appointment. Well, that's your top tier. If there's no activity going on to catch the majority of your patient base who aren't in the top tier, they're just normal people, then these folks aren't going to be calling you. These are the ones you actually have to chase a little bit. It's a majority of your patient base. It's more than half. So if your whole office has no follow-up, if there's no work on retention to keep these people on the schedule, then the only people you're going to end up with reliably on your hygiene schedule are the top-tier patients. So what's the problem is if after, let's say I'm in this scenario I gave you earlier, and I'm going to give you some estimates here. If you got 40 new patients a month or 480 a year, 2,400 over the last 5 years, a very small percentage of those are these top tier patients, really responsible, reliable patients. So, that might fill up, 2 days of hygiene, 3 days of hygiene. So your hygiene might only be one or two, one full-time hygienist a week, maybe one in a day. And you go into that hygiene schedule when you're trying to present treatment. The majority of these patients are top-tier patients. They don't need any treatment. So you look at the outstanding treatment coming in and there's nobody there because these are all the great patients who did everything you told them to the first time. Maybe somebody wants to get Invisalign done now or something, but it's not, you tend to at that point just focus on new patients because those are patients coming in who actually need stuff. Whereas the majority of your hygiene schedule, if it's not keeping up with where it should be, are patients who are already compliant. So someone needs to be going out and chasing, for lack of a better word, the majority of your patient base who, I'm not saying they're not good dental patients, but these are the patients that need to have a little bit of, reminder. They need to be chased, for lack of a better word, to get them in. Well, how much effort is involved in that? Well, let's say, for example, you have 4,000 inactive charts, which is, again, not an uncommon number. And you could just use this math any way you want. Maybe you have 2,000 inactive charts. I'm talking to a doctor recently who had 8,000 inactive charts. I remember talking to a doctor a few months ago who had 20,000 inactive. These weren't patients who were in 20 years ago. These people have been in the last 5-10 years. So if you had 4,000 inactive charts and you really wanted to reactivate these people, how would you do it? Let's think this thing through for just a second, okay? Because if you look at what's going to fuel your growth, why are you going to need more treatment coordinators or even providers, hygienists, associates, etc., is what's going to fuel your growth beyond excellent dentistry and great customer experience is more patients on the hygiene schedule, like keeping the ones that you have and getting in new patients. All right, well, we've talked about new patients a lot. Let's talk about this retention thing for a second. If you have 4,000 inactive patients, how often would we want to contact these patients to let them know that we mean business and want to get them back in? Let's say we want to contact them once a month. We're going to make an outgoing phone call once a month. We don't become a pest at that point. We're not calling every other day, right? But 4,000 patients, we want to call them once a month. We work 16 days a month. That's 250 calls, outgoing calls a day. So again, we're calling from a healthcare office now. This isn't a telemarketing company where we're just doing dials, where you're doing 100, 150 dials a day. We're doing probably less than that. Let's say we're doing 100 dials. Let's say we're doing 75 dials a day. That's a good number. 75 calls out a day. You also would hope that we're talking to some of these people, so it's not just like we're picking up the phone and dialing like crazy, right? So if we have 250 calls to make per day, we need 2 or 3 people on the phone full time to get these patients reactivated. Like you start thinking with the numbers, because I think this is what happens. People don't think with the numbers. And the longer I let these patients sit inactive and don't contact them, the better the chance that I'm never going to see them again. That's why I recommend that you have a practice newsletter of some kind that's sent out at least once a quarter, and it should go out to your whole mailing list, even if it's in plans that you dropped. Let's say you were in a bunch of HMOs and you went, to heck with these, I'm done with these, and you lost a lot of those patients. Well, they should be getting your newsletter once a month. And you go, well, Jeff, that's stupid. I wouldn't give them recall calls. Obviously, we're not calling them for recall, but why would we send them a newsletter? Well, in a lot of cases, folks, they may hate the HMO practice they're in. They loved your office and they may come back and just pay cash. Just saying, they're a name. They're somebody I met. They were my patient at some point. I'm going to continue to communicate to them. Yes, it's going to cost me 40 cents a piece to send this to them, but who cares? If anything, they may know somebody who would really love my office and they feel locked into that HMO practice and they may refer me some people. Okay, because they can't come. So you want to maintain communication with these people on a frequency to where they actually have a shot at coming back. So if that's the order of magnitude, how big of an effort I need to make if I really want to go after this in an active list. I need to make 250 calls a day. And I know you might look at that and go, well, that's just completely unconfrontable. I couldn't do that. Well, it's a heck of a lot better than making a call once in a while when people aren't busy. And start off with one person. But again, one person wouldn't be able to keep up with this. So do the math that way. How many inactive patients do we have? How many calls per day would that be per month? And how many people do I need? There's other things you can do too, because I get asked, what about texting and letters and emails? You should be doing those. You should be doing reminder software or text software. You should be sending group texts or things like this. The problem with that is, for the most part, you're gonna get the low-hanging fruit, if you're familiar with that term, right? You're gonna get the patients who are easy to schedule. Ideally, you would have it where if I get a text from your practice and I'm inactive, it has a link, which a lot of different software has this now. I don't know if you call it software as a service, things like Addit and things like this that hook up with your EagleSoft or Dentrix or Open Dental. But where I get a text, I click a link, and it brings me right to the hygienist schedule, so I can pick which hygienist I want to see, what's the next available slot, and make an appointment. You're going to get some appointments that way. You absolutely should, but you're going to get the low-hanging fruit. If you expect that to handle the entirety of your reactivation list, you're being a fool. Okay, not going to happen. You want someone, driving that effort, and you want to use the texting and the emails and whatnot. You absolutely should use them, but use them as an adjunctive or something to assist the forward motion. Don't think that that's going to do it all on its own. So the problem is, if you don't do this, then what's going to happen is your practice, your hygiene schedule is going to be full with patients who need no treatment. So you then become reliant on new patients. All right. So back to how this applies to our treatment coordinator position, because it's sort of what this podcast is about. You're going to need more treatment coordinators based on volume. I think 5-6 encounters a day, which allows enough time for the person to also be on the phone, is an adequate amount of traffic for a treatment coordinator. Some days may be busier, of course, but if you really want to make sure that they fulfill everything that they're supposed to fulfill, and this treatment coordinator can help with this reactivation process, as I was just discussing, they should be a big part of it, actually, especially getting patients in with incomplete treatment, right? But that would be about what a treatment coordinator should be able to handle if you want them to fulfill everything that they're supposed to fulfill, right? So those are the key factors, but obviously what's going to fuel your need for treatment coordinators, doctors, etc., is going to be the amount of expansion that's occurring in your practice. And again, the route to that expansion is going to be through hygiene and retention and new patients. So what I'd recommend that you do is take a look at where you stand. How many patient encounters is your treatment coordinator having, if you have one? How much outreach do they actually make on a given day? And, really look at it. If they call 4 to 6 patients a day and you have, 800 patients on your incomplete treatment list, that's probably not going to cut it. All right. I would also look at, if your office manager is being the treatment coordinator, how much time he or she is actually spending being the treatment coordinator, because you might need to bring somebody in to take that over, because then the manager's position is going to suffer because they don't have enough time to dedicate to it. You also might want to look at if there's been recent changes in your practice where you've all of a sudden seen a spike in new patients, or you're doing a new type of a marketing campaign, to see if you need to adjust those lines. Because for me, I don't know about you, but I don't mind. I don't mind spending money. I don't mind making an effort. I hate waste. I just have a pet peeve with waste. So, and you see it so much, pretty much, everywhere. I know I'm generalizing, but I hate waste. If we're going to go and market for a bunch of new customers, new patients, I want to make sure that we're taking care of each and every one of them at the same level that we were taking care of, we were doing before when we were getting less, right? So I have to make sure that I have the personnel in order to actually be able to do that. In any event, kind of a unique topic in this sense. I do hope that it helps. I have the links to what I discussed earlier with the YouTube videos on treatment coordinators, as well as the DDS Success course on treatment coordinators, if you want to check those out. If you have any questions, you can always email me directly at jeffb@mgeonline.com. We'll put a link on the episode webpage, or come visit us online at mgeonline.com or call us at 800-640-1140. Folks, have a great week, and we'll see you at the next episode.